We'll begin in 2 minutes.
Ross, we're live.
Very good. Good evening, everybody. We'll begin in roughly 2 minutes. Good evening, and welcome to this evening's community webinar on cutting-edge research at Columbia. Tonight, we'll discuss some of the latest COVID-19 research at Columbia University Irving Medical Center and how our faculty are investigating ways to better understand, prevent, and treat this disease. My name is Ross Fromer, and I am the Vice President of Government Community Affairs and Associate Dean here at Columbia University Irving Medical Center. I want to start by hoping everybody is doing as well as can be expected under these very difficult circumstances. For those who have lost friends and family members to this dreadful disease, I offer you my deepest condolences. May their memories always be a blessing. Before we start, I want to take a moment and read an excerpt from a statement that Lee Goldman, our Chief Executive Officer and Dean, sent to the CYMC community yesterday. What we have witnessed over the past week is causing all of us to confront the intolerable state of racial injustice that exists in our nation. The inexcusable actions that killed George Floyd, as well as other recent deaths and racially motivated events, are inconsistent with our basic commitment to a civil and just society. Columbia University Irving Medical Center insists upon diversity and inclusion, ranging from our student body and staff to our dedication to our neighborhood and patients. We will not tolerate racism or any of its manifestations. At this moment, however, we are appropriately concerned that the values on which the university and the healthcare professions are built are not universally shared, and that our nation is moving backwards. We cannot allow our leaders to dismiss these values any more than we can permit them to politicize our research or demonize researchers whose findings are not consistent with their worldview. We must ask ourselves what we can do in our professional and personal lives to help create the conditions needed for our nation and our society to move closer to the ideals that we cherish. To all of the CYMCA community, faculty, staff, students, our institution and I personally stand with you against racism, intolerance, and injustice. Even in this time of sorrow, let us resolve to be leaders in striving for a better future. You can read Dr. Goldman's statement in its entirety, as well as that of President Bollinger, on the Government and Community Affairs website. Tonight's webinar is hosted by the CYMC Office of Government and Community Affairs in collaboration with Community Board 12 Manhattan, the Health and Environment Committee, the Columbia University Department of Emergency Medicine, the Division of Infectious Diseases, the Northern Manhattan Center for Excellence in Minority Health and Health Disparities, and the Irving Institute for Clinical and Translational Research. I do want to take a moment to especially thank the staff of the Office of Government and Community Affairs for their help in making this evening possible. I should note that what you will hear tonight, this evening, is just a small sample of the research going on at Columbia and across the nation as the entire scientific community comes together to combat this pandemic. Over the summer and into the fall, We hope to host additional events where you can hear from other faculty about their COVID-19 research. Now, GCA has hosted about a dozen community research forums in the past. They were all in person. This is the first time we're doing it virtually. We think we have everything under control, but I hope you will bear with us if we have any technical difficulties. After the presentations, there will be an opportunity for Q&A. Simply type in your question using the chat feature, and we will feed it to the moderator. We will attempt to get to as many questions as possible, but feel free to follow up by sending your inquiries to cumcgca@columbia.edu. Please also send us any comments or suggestions you may have for future events. You can also check out our Facebook or follow us on Twitter. This Friday, June 5th, we will host a similar session in Spanish. Please see our website at www.gca.cumc.columbia.edu for more information. Finally, let me say that if you're interested in learning more about research at CYMC or participating in one of our studies, please visit our Recruit Me website at recruit.cumc.columbia.edu. There you can learn about all sorts of research, COVID-19 and otherwise, ongoing at Columbia. Now, at this point, is Congressman Espaillat on the line? Okay, he may join us later. So let me just move on to the program. It gives me great pleasure to introduce our moderator for this evening. Angela Mills is the J.E. Beaumont Professor of Emergency Medicine and inaugural chair of the Department of Emergency Medicine at Columbia University Irving Medical Center. Dr. Mills also serves as Chief of Emergency Services at New York Presbyterian West Campus. While so many of our faculty and staff have worked to respond to this crisis, the emergency physicians have been very much on the front line. She and her team of over 115 emergency medicine faculty, nurses, trainees, physician's assistants, technicians, aides, and volunteers have been providing the highest quality care to all who have come through the ER. Their work has helped inform treatment protocols and led to a better understanding of how to prevent and treat COVID-19. Dr. Mills, welcome. Thank you for being with us here tonight.
Thank you very much. It's my pleasure and honor to be here with all of you tonight. As the chair of emergency medicine for Columbia New York Presbyterian, I oversee the 4 emergency department sites, including the adult ER at 168th Street, the children's ER next door, the Allen Hospital ER in Inwood, and the Lawrence Hospital ER. And over the past few months, we've cared for extraordinary numbers of severely ill patients with COVID-19, which has really stretched us in many new ways. We've also seen many people suffer with illnesses at home because they were afraid to come to the ER. But as you'll hear tonight, we've quickly innovated protocols in our ERs and our hospital. We've developed new guidelines and programs, collaborated with other departments to improve patient care and follow-up. We've learned many lessons. We've also mourned together. We've been very grateful for the many remarkable acts of kindness in recognition of the frontline that we've seen from our community. And we've also witnessed COVID-19 disproportionately affecting communities of color, highlighting our nation's public health crisis of racism. And as Ross mentioned, this has been further highlighted with the recent killings of George Floyd, Breonna Taylor, and Ahmaud Arbery. As emergency physicians and as healthcare workers, we've committed ourselves to reducing disparities in the emergency department and to providing compassionate, high-quality care for all those who enter our doors 24/7, 365. As emergency physicians, we have an enormous privilege and a responsibility. We really act as the safety net of our society, at the forefront of social and public health issues, disease, new legislation, and unrest. We are with you, we value you, and we stand in solidarity with you, the community, and we are your partners in the struggle for change and equity. So it's my pleasure to be able to introduce some of our faculty tonight who will be sharing some of their experience, their work, their research to be able to improve patient care. I want to first acknowledge Dr. Rafael Lantigua, who's a professor of medicine and the Associate Dean for Community Service Programs, who is also here and will be helping to moderate the Q&A session. And first, I want to introduce Dr. Delavit Castor, who is an assistant professor of medical sciences in medicine at Columbia University Medical Center.
Thank you, Angela. Good evening, everyone. It's really a pleasure to be here as well. Let me pull my slides up. Okay, I can't seem to get. Pardon. Yeah, my slides are not presenting as an option. One second.
Janelle, can you help Dr. Castor out, please?
Sure, my slides are, when I hit share, it's not coming up as an option. It's not.
Can you make Dr. Castor the host? Okay.
Okay, let's see. Okay, great. Okay, can everyone see now?
Yep. Yes.
Okay, wonderful. It is really good to speak with everyone today. I will cover a few topics. The first will be on the biology, a little bit, a snapshot really of the coronavirus, what it is, a little on transmission, how it's transmitted. And as Dr. Mills and others mentioned, we couldn't have this session and not address a bit on the disparities in terms of how COVID has manifested in our population. So what are coronaviruses? The SARS-CoV-2 is the name of the new coronavirus that was discovered in China in late 2019. The virus that causes the disease is called, SARS-CoV-2 is the virus that causes the disease, and the disease itself is called COVID-19, which is short for coronavirus disease of the year 2019. The virus mostly infects the respiratory tract, such as the eyes, mouth, nose, and it's fairly widespread in animal populations. There are about 4 types, and the typical nomenclature is that they're called alpha, beta, gamma, and delta. On the right-hand side or your left of the screen, we have a heuristic that basically gives a simple description of the virus life cycle, which is it entering to the cell through these respiratory tract areas, and essentially goes through a cycle of producing new variants in the body. The virus itself is what we call a single-stranded RNA virus. And there are many other kinds of single-stranded RNA viruses. Some that you may be familiar with would be hepatitis C virus, West Nile virus, Marburg virus, HIV, Ebola, dengue, and many rhinoviruses. This virus, the SARS-CoV-2, is the 7th member of the family that has been known to infect humans. Of those 7, 4 mainly cause respiratory diseases like the cold, and 3 have caused severe respiratory diseases like the SARS-CoV-1 earlier, MERS, and currently the SARS-CoV-2 virus, which is the cause of COVID. As I mentioned, it is transmitted through respiratory tract and primarily through droplets of saliva and or mucus. Typically, the virus is expelled by individuals through a cough or talk. Many would have seen recent news reports where a choir also had very high infection rates, so people ask questions about singing. Certainly, the droplet, as far as we understand, can travel about 6 feet and remains infectious for about and up to 48 hours, and that may vary depending on the surface type. Transmission may also occur if the person touches an infected surface. There are still questions about how else the virus could be transmitted, and this is part of ongoing investigation. In the middle of the slide, I show sort of like, the four different ways how efficient the virus can be transmitted through these different mechanisms of transmission. So sneezing, as you see, produces a lot more virus relative to like coughing or talking. On the furthest right, I have an image of prevention practices. However, other speakers will address that quite a bit. So here we go through a bit of the transmission of SARS-CoV-2, which was first identified around December 8th as the first case in Wuhan. And then the actual virus itself was identified on January 7th. And then by January 30th of 2020, it had global alert, the first case in the US in late February 28th, and in New York City on March 1. And by March 11, the WHO had declared that this was a pandemic. It's quite striking when we look at the fact that this is only 154 days into the epidemic. I think for many who are working on it, it feels like far longer than that. And to date, we have more than 6 million cases and globally 365,000 noted deaths. In the US and elsewhere, older age has been a factor that's been associated with worse outcomes with COVID-19. In some instances, male sex also seems to be associated, and also having higher body mass index. We've also seen associations with other comorbidities like cardiovascular disease, diabetes, chronic lung disease, high blood pressure, and cancer. And in the US in particular, we've seen pretty striking differences by racial and ethnic identity, with Black and or African Americans showing the highest rates of hospitalization, non-fatal hospitalization, and infection. On the right-hand side here to illustrate this, we use data from New York City, but the trends have been observed throughout the country. So these are factors that are both individual level traits and also the way we can characterize what's happening in the country. On the left-hand side, we have other, this is a geographic map of the distribution of COVID-19 across the country, and it highlights vulnerabilities in different geographic spaces for responding to COVID. And they're based on things that we know affect also disease outcomes, like the physician capacity, socioeconomic status of that geographic space, human resources, and the time periods when COVID might peak. On the right-hand side, I have the distribution of COVID in New York City. And as you can see, particularly on the island of Manhattan where we live, the density or the number of cases per geographic area gets deeper and brighter, representing more cases as we get into Upper Manhattan where we're situated. So the discussion around the disparities that we see with COVID transmission in this country really shouldn't be whittled down to just measures of racial or ethnic identity, because those really mark a number of other phenomena and things that are happening in our society that we really classify as our social determinants of health. And some of those attributes, and this is by no means a comprehensive set of descriptions, include economic stability, the social and community context in which this is happening, neighborhood and environmental factors, and that could be even at the household level. Also healthcare, access to insurance and coverage and access to care, as well as education and employment functions and roles. We've seen and described the importance of essential workers throughout this epidemic and the disproportionate representation of people who identify in these different racial and ethnic groups within these essential employment definitions. Again, in the space where we live, what we see is that this is really a very different story by geography. And in in Manhattan, for instance, 9 of the top 10 zip codes where we have the highest prevalence of COVID are located above Uptown, above Central Park. The communities all these communities are marked by lower income status and include primarily and disproportionately people of color. Washington Heights and Inwood, where we are situated, tallies the highest percentage of positive tests. And my last slide is really that, today, as I've started with giving a description of where we are in the epidemic and the transmission of this virus globally, nationally, and locally. And just in the course of what has transpired over the course of this week, the most current estimates that we've already identified over 21,000 new cases amidst the response to the disparities and injustices in the country. And I'll stop there.
Thank you. And Angela, I'm going to break in here for 1 second. I understand that Congressman Espat has joined us.
Yes. Hi, Ross. Hi, everybody. Thank you for having me on. This is an important discussion. And as I just tuned in a little while ago, I heard the numbers, and basically this pandemic has unveiled what we already knew, that our neighborhoods suffer from these great disparities in health care and in health conditions, and that we have high numbers of diabetes and high blood pressure, and respiratory diseases, and cardiovascular problems, all of which have manifested themselves in a deadly way in this pandemic. But I do want to thank everybody that Columbia and New York Presbyterian for doing a great job. And as we fight for the HEROES Act, which is lots of money for the city and the state, just like the state argue, I may add justifiably, that we should get more funding because New York State and New York City were the epicenter of this pandemic. I believe that our neighborhoods also deserve to have a greater portion of the pie so that we can break the perpetuity of these healthcare disparities that are deadly. Men like me, Latino men, high blood pressure, we have a target on our back with this pandemic. If you have diabetes, you got a target in your back. And so we lost a lot of people, and I think one of the weaknesses was that we failed to isolate people early. And so when they got tested positive, they went back home to these overcrowded apartments where you had grandma living there taking care of your kids while the couple went to work, and everybody got infected. And so that's why you had these high numbers of COVID-19 positive cases and high numbers of deaths and people on ventilators. But this is an important discussion so that we can get ready for the future and to ensure that this doesn't happen again. Thank you so much for having me on, and thank you for all you do.
Thank you, Congressman. Angela, could you introduce the next speaker?
Sure. Thank you, Dr. Castor. It's my pleasure now to introduce Dr. Marie Romney, who's an assistant professor and vice chair of quality and patient safety for the Department of Emergency Medicine at Columbia University Medical Center.
Thank you, Dr. Mills. As you all know, New York City quickly found itself at the center of the COVID pandemic in the US, with our emergency departments here at Columbia serving as the front lines in the battle. Faced with large volumes of very sick patients, we had to quickly innovate on new care delivery models to meet this increasing demand, while also making staff and patient safety one of our primary goals. Oops. So I'd like to spend just a few minutes talking to you about the volume of COVID-19 cases seen both in the city and here at Columbia, and talk a little bit about how we responded to these numbers. Then I also want to move into the prevalence and hospitalization numbers and how those changed over time. And finally, what we're doing now to keep everyone, both patients and staff, safe in our EDs. So the first confirmed case of COVID-19 in New York City occurred on March 1st. And as you can see from the graph, the volume of cases quickly surged, reaching a peak in early April, before the volume of new cases started to decline. As of this morning, there have been 208,550 confirmed COVID cases in New York City. with 21,090 deaths so far. And as you know, testing capacity has been an issue across the country. So these are, again, just the confirmed numbers that we have. Thankfully, that's improved significantly. In our EDs, we're now able to offer testing to any patient presenting to the emergency department with symptoms concerning for COVID-19, even if they're being discharged home. The map on the right, which I believe is similar to the one that Dr. Castor showed earlier, is basically showing the case rate by zip code. And as you can see, this pandemic has affected some areas of the city more than others, disproportionately impacting communities of color and those areas with lower socioeconomic status. These variations had a big impact and contributed to the volumes that we were seeing based on the communities that we serve. Thankfully, we've seen the volumes of cases come down in the past few weeks, which is also reflected here in the graph that I have on the left. But it's lowered the volumes across the city and also the volumes that we're seeing in hospitals. These next set of graphs are essentially showing numbers related to admissions at our two main campuses, Milstein and Allen. The green lines are depicting the percentage of admitted patients that were tested for COVID, and the blue line is the percentage of the green line is depicting the percentage that was patients who were admitted who got tested for COVID. The blue line is showing overall of all comers the percentage of patients that we were testing, and the red line is essentially showing the percentage of admitted patients that tested positive for COVID. As you can see, again, during our peak periods in early April, upwards of 80% of the patients admitted to the hospital were found to be COVID positive. The numbers were even higher at Allen, reaching almost 90% at peak. In response to these surges, we quickly innovated and created new care models, including new applications of telemedicine that allowed us to keep patients out of the ED that didn't need to be seen in person. We created a follow-up program using remote patient monitoring, which basically allowed us to send home patients that would have otherwise been admitted to the hospital. And within the hospital, we had specialized response teams that were focused on addressing particular needs for these patients, including an airway response team, procedure teams, and a dedicated team to interface with patients and their families using iPads, as visitors were not allowed to be bedside with their family members. Thankfully, in the past couple of weeks, we've seen the number of patients being admitted with COVID-19 plummet to values less than 20%. So we've definitely been successful in flattening the curve. While the volume of patients presenting to the ED with symptoms concerning for COVID have diminished significantly, given the natural progression of this disease, the length of stay for admitted patients is still quite long. And so while new admission volumes have come down, we still have a significant number of admitted COVID patients being cared for in our hospitals and ICUs, which is what's reflected here on the graph on the left. These numbers are representative of all of the NYP hospitals. The curves are moving in the right direction, following a similar curve to what's being seen in the city overall, which is what's reflected in the graph on the right. However, we still have a good number of patients on ventilators and in ICU beds throughout the system. A message I would like to emphasize to this group is we're doing everything we can to keep our patients safe when they visit our EDs. We've created high-risk and low-risk care areas to minimize exposure for patients presenting with non-COVID related complaints. Our frontline staff continue to wear full PPE 24/7 in the ED, both in these high-risk and low-risk areas. This is not just for their own protection, but also to protect new patients who are coming into the hospital. So I just ask to not stay home if you're experiencing serious medical complaints for fear of being exposed to COVID if you come into our EDs. We're finding many patients are waiting too long and coming really far into their disease course before seeking out care. I can assure you that we are prepared to safely care for anybody that's coming through our doors. With that, I'd like to hand this off to Sion, who will speak a little more about the safety of seeking out care.
Thank you, Dr. Romney. It's my pleasure to introduce Dr. Sion Faru, an assistant professor of emergency medicine at Columbia University.
Thank you, Angela. So Marie had talked about what are the kind of interventions that we have made in our emergency department in the past few weeks, in the past few months now. And so I'm going to talk about what are the kind of things that you're going to do to stay safe And of course, if you have to come to the emergency department, we'll happily take care of you. But what we know so far, and as one of our panelists will talk about cure and vaccines, at this point, we don't have neither. So prevention remains the best cure. And as we say in public health, an ounce of prevention is worth a pound of cure. So it just means that if we ensure that we prevent the disease, then you will avoid the troubles and complication of the disease, especially that has been ravaging throughout our community. And believe me, I can also, since we've been encouraged to talk about personal anecdotes, I also had it, and thankfully I was able to recover just by staying at home and resting, and my husband also had it. So if you can avoid it, it would be a great thing. Once you have it, of course, our doors are open to take care of you. One thing I know, staying at home, which was what we've talked about, what people tell you, and especially during the stay-at-home orders in New York. And people do call us heroes since we work in the hospital. We're trying to save lives, but I really think, especially families who are forced to stay at home and actually implementing that are the true heroes, because the prevention still remains the most important cure. And I know it's been very difficult, especially for people with large families with kids, having to teach your kids through different means. So I understand it's super challenging. So it's very important that when we come to the prevention methods and some of the things that we've talked about and that's been discussed earlier, staying the 6 foot, as our panelists have described it before us, what like droplets could cause, and wearing mask and some of the interventions and staying the 6 feet distance has been shown to work and improve. And if you talk to most of us in our emergency department, we've actually witnessed this firsthand. Once the stay-at-home orders went in, and as Marie showed you on the graphs, it was just like magic. The numbers dropped significantly. And now thinking about what it was like during the peak, just felt like the near was not, the end was not near. And really some of the things that really helped is the stay-at-home orders. People staying at home wearing masks, and if they're symptomatic and if their symptoms are really bad, they'll come to emergency departments. But staying at home, it really saved lives, and I will congratulate all of you guys for all the work that you've been doing when staying at home. Next slide. So Marie, next slide. Thank you. So some of the things we've talked about, and especially in our community, why our community of color seemingly more susceptible. And as the congressman has explained it earlier, there are higher rates of pre-existing conditions like diabetes, high blood pressure, heart disease, and age also seems to be a high risk factor. And what we know so far, when we talk about the racial injustices that have occurred recently, what we talked about in media, but really also within medicine itself, there exists lots of injustices due to race and ethnicities. And what we know so far, most of the data that we have is people of color are less likely to have access to medical facilities, to insurances, and to primary care doctors. What we were actually recommending to do, even at the beginning when people call, we'll tell them to go to their primary care doctors, but most of them did not have a primary care doctor. So that seems to be another challenge to our community. And also a lot of our community have multi-generational housing where people of different generations live in the same household. So it's been very difficult for people to have their own bedroom, their own bathroom, which has been also difficult when we recommend for the patients to do at home. So sometimes also with people having access to essentials, and also people having to go outside and go shopping or grocery shopping, maybe not having somebody to support them. So that's been some of the challenge that we've seen in our community. Next slide. So what are the kind of things that you can do despite the challenges? I think at this point, a lot of places in New York, especially even our emergency departments, have extensive access to testing, which we didn't have. If you go to the Department of Health website, they will tell you the places nearby you can go get tested. So now they're also offering antibody testing. So I think getting tested, even doing it as a family, whether you have an active disease or whether you have an antibody, would be something very, very important. And also implementing the CDC guidelines when it comes to the physical distancing and wearing masks. And some things that I know it's been very challenging for people, the community, and also all of us personally, that we are having to get used to our new normal, which is to coping with stress. We are not allowed to hang out with big crowd, especially with the summer. People would want to go outside and have the block parties and all the fun things, but that's going to change, and we're not going to go back to our how we were before the pandemic until we get vaccination, until we have a cure. And one of the panelists will talk about it afterwards, but I think we have to find a way to get used to the new system, which is like having a webinar through Zoom, which I understand is the first time doing it, and also finding a way to still have that face-to-face with your loved ones. I started doing a movie night with my niece and nephews through Zoom. So the kind of things that you will be able to continue with if you were not forced to do the physical distancing. Next slide. One of the things I think also could be a question to the community here, as New York, as being a sanctuary city, Open Society Foundation have now find a way to fund emergency relief programs. We will ensure all New Yorkers, regardless of their immigration status, are including the citywide COVID response and relief efforts. And my understanding is also, of course, in our emergency department, and also in most of this COVID-19 testing places in the church and the community, they do not ask for immigration status. So if that is a concern, we encourage you guys not to worry about that and go get tested. And these testings are available everywhere. So really to take advantage of it, because it's just been multiple advocacy work that we're finally able to get this number of testing, because a few weeks ago, we all struggled getting tested and also testing on our patients. Now that we have it available, and it's the best way that we can contain the disease and make sure it doesn't spread to your loved ones. So if you haven't got tested, we encourage everyone to get tested. Thank you.
Thank you, Dr. Farouk. It's my pleasure now to introduce Dr. Magdalena Sobieschek, who's an associate professor of medicine and also the chief of the Division of Infectious Diseases at Columbia University Medical Center.
Hello, good evening, everybody. And thank you again for the opportunity to share some of the things that have been taking place at Columbia University Irving Medical Center. And I'll talk to you specifically just about the ways that we've been working on finding new ways to prevent COVID-19 infection. I just have a few slides to share with you tonight. Perfect. So as I mentioned, what I'll be talking about, just kind of talking about the developments and new ways of prevent SARS-CoV-2 infection that causes COVID-19. So as you've heard, and many of you already know, is that there are some very effective ways of protecting oneself and preventing transmission of COVID-19 or and the virus. And that really is sort of rests on sort of the concepts of hand washing, infection control and prevention, covering the coughs and the sneezes, covering the mouth and the nose with a face mask, cleaning, careful cleaning and disinfection, and then the social distancing, which I think is one of the hardest things that we have to do as people. That's sort of the avoiding the close contact, and that's particularly hard nowadays. So I just wanted to share with you some thoughts and updates about how investigators here at Columbia Medical Center and have been pushing the envelope and trying to find some cutting edge ways and new methods of preventing COVID-19. And that really has been possible thanks to the research that has been done in understanding how not only the virus replicates, but how it enters the cell and how it causes infection. And you've heard that about that a little bit from Dr. Castor. So understanding really that and understanding what are kind of the points of vulnerability on the virus has really made it possible for us to think about testing medications or anti against the virus to prevent the infection, looking at antibodies against the virus that can be used as a prevention method, and then vaccines. And really what I want to focus on just briefly is just telling you about the developments in testing and development of antibodies against the virus as well as the vaccines. So let's talk a little bit about the antibodies against SARS-CoV-2 that causes COVID-19 infection. So as you may know, antibodies are really one of the most important ways that a human body's immune system fights infection, either bacterial or viral infection. And these antibodies attach themselves to the outside of the virus in this case to block the virus from entering the cell and from establishing infection. And in case of SARS-CoV-2 virus, the spike protein that sort of studs the surface of the virus is really oftentimes the main target of these antibodies, not the only target, but the main target. And the antibodies here at our institution, as well as other institutions across the world, antibodies that are capable of blocking the virus have been identified from patients who've been infected and who've recovered from COVID-19. These antibodies can be purified and infused to help treat or prevent infection. And clinical trials are taking place at Columbia right now and across the city and across the world that are testing whether or not the infusion of these, what we call convalescent plasma, so plasma that contains antibodies from people who have recovered from infection, and infusing that into someone who is either ill, whether or not it can prevent progression of the disease, or it's also being used as a prevention or prophylaxis method. And then also equally exciting is the fact that not only can we identify the antibodies that develop in individuals who get infected, but we can also, there's sort of a lot of research that's happening at our institution that's enabling investigators to select the most potent antibodies, those that bind the best, most potently to the spike protein, especially on the virus, and prevent the virus from replicating and from entering the cell. And then selecting those antibodies and infusing them as in a combination or as a single infusion is also going to be investigated very soon at our institution, both for prevention and for treatment. So those are some really quite cutting edge developments that have occurred in the last several months and are taking place certainly here at our institution, and doing clinical trials where we test these antibodies for treatment or prevention is something that's going to be taking place at our institution in the near future. What about vaccine? So many of us believe that just like for other infectious diseases, a vaccine really is one of the most promising ways of trying to stem the tides of any epidemic or a pandemic. Ideally, especially if it's a vaccine that can be administered once and can protect someone from infections for a long period of time. So what a vaccine does is that it carries instructions for the body to make an immune response that can either block or kill the virus if and when a person becomes exposed and infected with it. And what's been remarkable actually is that since the discovery of SARS-CoV-2 virus, a large number of potential vaccine candidates have been developed and are being developed by institutions across the world. A few of these candidates have started testing in clinical trials in people to evaluate their safety and to evaluate the type of immune response that they can stimulate to see whether or not that immune response can potentially be protective against infection. So as I mentioned, these few of these vaccine trials have started testing in people. So what is the goal of such a vaccine, and what is the potential benefit that it would offer not only the individual, but the communities around them? So such a vaccine, the goal is that it would help prevent infection and prevent development of the disease, and then prevent further transmission, thus benefiting the community around us. And then sort of the concept, another concept that's important sort of in developing vaccines is this concept of herd immunity, meaning that even if only some of us get vaccinated, making those individuals less likely to transmit the infection to others, then the rest of the individuals around those vaccinated people will derive some protection as a result of it. That is especially important in circumstances when it's not possible to vaccinate everybody once there is an effective vaccine. So we're not quite there yet. We don't have an effective vaccine. There is still some time off. But as I mentioned, that there are a number of possible that COVID-19 vaccines in development, and this sort of picture kind of gives you just a snapshot of how many are being worked on in the laboratory, kind of at the planning stages, how many have entered some testing, early testing in animal models, and that a few of them have made it into clinical trials in people. And the process of testing these vaccines, just like it is the same process for testing any intervention, any biomedical intervention, such as a medication, it's a careful, well-designed process that goes through different phases of testing. So there are sort of phase 1 trials that really look at safety of vaccines, phase 2 trials that sort of go into more people, that look at the safety and also immune responses that a vaccine may stimulate. And the goal of these studies is really to test, to find the best dose or the best schedule for a particular vaccine. And then phase 2, sort of slightly more advanced studies are starting that look at the safety and immune responses of these, that these vaccines can stimulate, to see whether or not a decision can be made to go into phase 3 testing. And a few of these COVID-19 vaccines are actually at a stage of phase 2, phase 2B testing, so that we're getting ready for what we call an efficacy study or phase 3 testing, where many thousands of participants are going to be invited to participate to test whether or not a vaccine can protect from infection. And we're actually going to be participating in this global effort to test these COVID-19 vaccines. And we'll be doing this in the context of our Columbia Partnership Clinical Trials Unit, which will be part of this new COVID-19 prevention network that's really pulling a lot of resources together to try to find a way to prevent COVID-19 infection, both through vaccine research and through the antibody research. And I just wanted to highlight to you that we, as part of our clinical trials unit here at Columbia, we have 4 very experienced clinical research sites that are located right here at Columbia, and at 2 or 3 other neighborhoods around the city, in the Bronx, in Harlem, and on Upper East Side, sort of in the Neuro Blood Center. And as you can tell from the map, these clinical research sites are located right in the midst of kind of areas in our communities that have been hardest hit with COVID-19. So it is fitting that we make these clinical trials available and accessible to communities hardest hit by this illness, and we make sure that we educate and outreach to these communities so we are all aware of the cutting edge research that is taking place. And we're now preparing to start phase 3 vaccine efficacy trials this summer, and several more will be starting in the fall. And these studies, as I mentioned, will really reach out to thousands of participants to test whether a vaccine is safe and if it can protect from COVID-19 infection. These vaccine candidates that we will be testing are currently being evaluated to make sure that they're safe and they're well tolerated before we move into the efficacy testing. And I'll be happy to share more information about that with you either now or at a later date. I just wanted to end with kind of a word of thanks and deep appreciation for the work that's been going on, not only at our medical center, but it's really been thanks to kind of the communities around the medical center, our partnerships with community-based organizations. We're forever indebted to our study volunteers and their families. For without them, we wouldn't be able to learn as much as we have learned about kind of understanding the virus and learning how to prevent it. I should mention that conducting in clinical trials in the midst of a pandemic is a great privilege and has been an amazing learning experience for me and my colleagues. And it is through these clinical trials that are designed very carefully and conducted carefully and safely that we have learned a lot about COVID-19, and we will continue to learn a lot about how to treat it and how to prevent it in our communities. Thank you.
Thank you. It's my pleasure now to introduce Dr. Murdoch Riley, the Florence and Herbert Irving Endowed Professor of Medicine, the Director of the Irving Institute for Clinical and Translational Research, and Associate Dean for Clinical and Translational Research for Columbia University Medical Center.
Good evening. It's a great pleasure and privilege to be here this evening. Can everybody see my screen? Good. So I want to first thank my predecessors this evening. These are some of the heroes at the front line that have worked in the emergency department and the infectious disease service at Columbia NYP to really look after the devastating pandemic in Upper Manhattan. I'm a cardiologist and I work clinically, but my main role here this evening is to talk about the job we do for research at the Irving Institute. So the Irving Institute is an institute that supports clinical and research in communities and in clinical care and towards trials at Columbia. It's also called a CTSA because it's a part of a network of about 50 centers across the United States that have similar support at universities and medical centers to support research. So I'll talk a little bit about how we support research in general, then I'll talk a little bit how that fits into COVID, and then I'll give you some examples of what we're doing with COVID-19 at the current time. So
Dr. Riley, could I ask you just maybe if you could put in presentation mode?
Oh,
It
excuse
might be
me.
a little bit easier for the audience to see. Thank you.
Thank you, Angela.
Thanks.
So the mission of the Irving Institute, as stated here, is to advance discoveries and knowledge and innovations to improve human health across the lifespan for our diverse populations in Upper Manhattan and around the world with our partners across the other institutions that have CTSAs. And we do this, and we do it with respect to COVID-19, but in general, we've been doing it for the last 15 or 16 years at the Institute through a series of services and support mechanisms. And these include consultations to help people do research and clinical research, services, funding towards research, and particularly education and training. So for example, under consultations, we have consultations which help with development of therapeutics and new medicines. Under research support services, we have space for clinical research and clinical trials. And we also have a site in two sites in Upper Manhattan for community engagement. And we've had programs, for example, at 175th and Fort Washington for the last 12 years, engaging community in health and healthcare and research. We do provide a lot of funding to support ideas of our investigators at Columbia to get their projects going, and then for them to get larger grant awards towards larger clinical research, for example, like clinical trials. And last, we spend a lot of time educating our faculty and our trainees to do clinical research and translational research. So it's simply stated, what we do is we take the ideas of our brightest and best faculty, clinicians and researchers and help them and guide them through training, services and funding to take their ideas into a scientific outcome related to healthcare, health and well-being. And so, for example, this could be development of a therapeutic or a treatment. And as you've heard in this case, antibodies or convalescent plasma or vaccines for COVID-19. So where do we fit in the spectrum of research for health, and in this case for COVID-19? We provide services and support for laboratory research, but predominantly our support is for clinical and preclinical research. So developing new therapies and thinking about how we get those ready before they're suitable to put into to do trials on in patients, and then developing treatments for patients. And in particular, we provide support and services to help understand clinical disease in patients and in patients in our communities. So understanding the underlying health conditions, particularly in Upper Manhattan, socioeconomic settings, and in health disparities. What are the social factors? What are the biological factors and genetic factors that may interplay in these circumstances in our clinics and in our communities? So we really are engaged from the lab to the clinic all the way into community. So how do we do this with respect to COVID? And here are some examples of what we've been doing. So you've heard from Dr. Sobiushi about some of the clinical trials that are ongoing. So in fact, some of the first clinical trials to use the antibodies that she's described have been performed in the facilities and the support services that are at the Institute. And in this difficult time, it's a privilege and a challenge to actually do trials in a safe and effective manner for patients and for participants, and particularly for prevention trials at the medical center when there's been a pandemic. So we've been supporting trials that we've heard about. We've also established a COVID-19 biobank and clinical data resource for researchers. For us to understand how COVID-19 affects and is causing higher rates of complications and death in our communities, we need to study our communities, and we need to be able to understand what's happening in patients from our communities. And in much of the last 50 years, most of the research that has been done to try and understand disease in humans has been underrepresented in minorities, and particularly in communities and in our communities in Upper Manhattan. So in this case, we really need to have resources that reflect the communities that are getting the worst hit by the disease to understand what's happening. So for example, the antibodies that are critical to understanding what's happening, therapeutics that might be using antibodies or vaccinations, may have different responses in different people by sex or by gender or by ethnicity. And unless we study that, we won't really understand it. So that's one of the purposes of the biobank. We also have active programs in community and engagement, I'll talk about, and education and training. So in the biobank, what we've done so far in the last couple of months is somewhat remarkable because of the participation of our patients in research at this time. There's been about 7,000 patients with COVID-19 at our hospital at the medical center. And of that, we have had participants volunteer and participate in research through remote consenting after they've gotten infections. And we've approximately 70,000 samples collected from those patients when they have come through clinical care. And we've established the governance structures and committee structures to facilitate the use of the samples for research. And in all cases, the samples and the data that are used are de-identified from the personal identifiers so that research can be done in a de-identified manner. So far, we've already seen use of this biobank for over 90 research projects, which are leading to new discoveries and new knowledge, which are particularly relevant to the patients who come from our communities, are studying antibody responses, studying why there might be differences in why patients get more heart disease if they have hypertension. If you're diabetic, why is there greater risk of getting complications of the disease? So we have also, for the past 12 years, had a community engagement core resource, which has been active in Upper Manhattan and Washington Heights and Inwood, and more recently in the Harlem communities, and with 2 physical locations for engagement of our communities. And this has had a variety of stakeholders engaged over the last number of years, particularly faith-based organizations in Harlem and community-based organizations in Washington Heights, as well as our investigators and community members, and what we're calling our community ambassadors, who are community leaders who engage with us actively and advising us about how to engage communities and how to do research in communities. And then we implement with the community and faith-based organizations trying to build capacity through education and research, and connecting across other academic centers across the US to connect community programs relevant to our communities. And that's relevant to think about how we need to do trials, for example, when we need to have multiple institutions across the US, where there will be representation of the communities that are like us in Northern Manhattan. To really be able to capture that across the US means we have to reach out further for the larger trials and the larger studies. So we've had a lot of different types of engagement, and Dr. Lantigua, who's on the call with us this evening, has been a leader on many of the programs that we have had. I just see if I skipped a slide there. Yes. Whoops. 1 second. I'm having trouble with my screen, excuse me. Can you still see my screen, my slides?
Yes.
All right, that's just on my side then. I'm going to try and see if I can get the slides. Yes, I got it back. Excuse me. So there's been many projects going on in communities since the start of the pandemic, and these have included the initiation of research projects with Dr. Williams in neurology, who's part of our team in community, looking at the impact on churches, a tracker of disease and COVID-19 symptoms, and a community survey, which has been implemented over the last couple of months. There's also been a website where we've disseminated information about health and risk and facts about COVID-19, and also educational programs and initiation of mental health initiatives in the community to help our communities that are suffering tremendous mental stress during this time. And Dr. Lantigua in particular has been engaged in service across the community and communication across the community. Dr. Williams, who's one of our community program members and neurologist, has been very active in the community in Harlem in particular for a number of years, and has engaged in developing this video promotion with rapper Doug Fresh on hand washing in community and as a prevention for COVID-19. So with that, I'd like to finish and just let you know that there's 70 faculty and 60 staff in the Institute that are focused on research and predominantly focused on COVID-19 pandemic at this time. In particular, I'd like to reach out and say at this time of great devastation in the communities of Upper Manhattan and New York City, and at this kind of shameful time in our society of racial injustice, I'd like to say that we're here for you and that we're listening, and anything you want to hear about with respect to research going on at the medical center and going on in the community programs, we're happy to talk about it, and you can find us through the website. And Dr. Lantigua is a leader in our programs and is also available to connect with the communities. Thank you.
Thank you to everyone for really terrific presentations. I think we're going to start now into our question and answer session. We've received a number of questions. Maybe I'll throw out a question there and see who would like to answer. The first one is if someone could please elaborate on what parents can do as they begin to leave their children at daycares. Maybe Dr. Sobieschek, if you want to answer that one.
I was on mute. Yeah. Yes.
Okay, got it. Yep.
That's sort of one of the kind of tougher questions that's facing all of us, and certainly facing parents. I think, especially since kids, regardless, respective of what age they are, they don't follow social distancing, and trying to get them to keep masks on is sometimes nearly impossible. I think the key things would be to sort of making sure that partnering with the daycares and sort of understanding what infection prevention and control measures they are instituting to make sure that the kind of sort of the basic issues of maintaining sort of a clean environment and cleaning in the morning and cleaning, kind of wiping down surfaces, that's followed, and sort of partnering with them to sort of make sure that kids, to the extent possible, who may be symptomatic, stay home so that they don't infect others. And then I think emphasizing, to the extent again possible, sort of about wearing masks and washing hands, and sort of teaching children to do that, I think is important, and making sure that you know, as we discuss with our sort of with the daycares and school and or camps, whatever they may be, sort of what measures they're implementing to do so, I think will be important. But it's an evolving conversation that I think needs to be happening, because I recognize that it's very difficult to implement these infection control and prevention measures. And it would be great to actually hear from other panelists, sort of as, you know, as we all sort of struggle with this, how do you maintain kind of these measures, and how do you teach your children and enforce in a way kind of these infection prevention and control measures, especially around play dates, right? That may or may not be happening. So I don't know, practical tips.
Great. Yeah, that was great. Thank you.
Yeah.
We have an additional panelist, Dr. Stephen Morse, who's joined us, who's a professor of epidemiology at Columbia University Medical Center and at the Mailman School of Public Health. So we'll hear his presentation, and then we'll return back to our question and answer period.
Thank you. Hello, and I'm glad to join you, even if a little belatedly. So the Mailman School of Public Health is Columbia School of Public Health, and it's been here for almost 100 years now. We'll soon be celebrating that. And we are interested in public health, which is prevention. Mostly, how do you prevent things like infections and other illnesses from getting around and catching people? What can we do? So many of the questions that have been brought up involve public health questions. How could we have stopped this pandemic in the early stages, which is a question of particular interest to me as an epidemiologist. Now we don't have to define the term the way we once did, but epidemiologists are people who study the patterns of disease in populations. So we're interested in things like, what is the effect of immunization? How effective is vaccination? How does this infection spread? My field is infectious disease epidemiology, so I'm interested in knowing things, how many people are infected? How does it spread? What can we do to prevent transmission? But public health is a very broad field that includes many different categories. So I'll mention some work done by some of our colleagues in the area of SARS coronavirus 2, or the disease which we call COVID-19, coronavirus disease 2019. Ian Lipkin has a large laboratory that's been working on a number of viruses for a number of years. And one of his interests has been ways to better identify and detect new viruses before they reach the human population. That's an area I've been interested in also. And diagnostic measures. So they're working very hard in Dr. Lipkin's laboratory, among other things, to look at ways to better diagnose and how stable the virus is under various conditions, and many other things. A lot of the work he does falls into the category of what we call pathogen discovery. And for about 5 years, in fact, I was the co-director of a project called PREDICT, the purpose of which was to identify what's out there in the natural world, the next SARS or something like that, that could come, like this one, by surprise and suddenly hit us. So that's a big research effort that involves, obviously, a lot of hands-on research. Ian himself was actually in China a few months ago, helping the Chinese scientists deal with the SARS coronavirus 2 now pandemic than a more localized infection. And he had gone in 2003 to China to help with SARS. So he has a long experience in this area. Simon Anthony, another colleague who also worked on the PREDICT project and is in Ian's lab, is interested in the diversity of viruses. One of the questions being, how many viruses are there in the world? And we actually all published a paper some years back, trying to count, essentially estimate by statistical measurements, how many viruses there are. And I just saw something today in the paper, I think was in the Times, it says trillions, but actually we thought it was somewhat less than that, although the number is still very large. And Simon has been looking at the relationships of various coronaviruses, how they're related to each other, the ones that come from bats, as many of them do. What does their family tree look like? Obviously, to better understand these viruses and better understand what might be out there waiting for us, as this one has been. Other colleagues, Jeff Shaman and Andrew Rundle. Jeff Shaman is in the Environmental Health Sciences Department and does what we call modeling, which is trying to forecast and find out or figure out, as with weather forecast, what the infection is going to do, where it's going to go, and what effects it might have in the future, and how we might obviously bend the curve to change that. And he's been doing that with flu and Ebola during the 2014 Ebola outbreak. And you've probably seen some of his work in the New York Times or even referred to on television. That's the work at Columbia that you've heard about, trying to forecast what this infection is going to do. And I think it still has a long way to go. Andrew Rundle, in an environmental epidemiologist in my department, epidemiology, has worked with Jeff and others to look at mapping not just the occurrence of the disease or of the infection, but also the effect on hospital capacity and on our infrastructure. So I think those are important areas. And we have a number of people who are interested in social epidemiology, as we call it, or in the Department of Socio-Medical Sciences, interested in the effect of these infections like COVID and SARS coronavirus 2, the virus that causes it, on minority communities, on African American, Hispanic, and other communities of people of color, and why they're so hard hit. So Dr. Bob Fullilove is very well known for his work for many years in that area, but we have others also who are interested in the question, why are some groups always the ones who are most disadvantaged in other respects, more greatly affected by this? Why is the death rate higher? And that's obviously also a question of justice. And social justice is one of the things that public health stands for, making people healthier in whatever way we can do it at the population level, and also obviously making sure that resources are more equitably, more fairly distributed. My own work, as I mentioned, is in infectious disease epidemiology. And back about 1988, I became interested in the question of what I then called emerging infections. I was working in the lab then at the Rockefeller University downtown from here. And one of the things that was really puzzling was, where were all these infections, like back then HIV/AIDS and influenza pandemics, and then in 2003 SARS and the bird flu? Where were these coming from? Why were they happening? So back in the 80s, I became interested in this question, egged on by some of my colleagues at Rockefeller, and developed a framework for thinking about emerging infections. Most of these are really coming from other species we have contact with. This coronavirus probably came from a bat, and so did SARS, its closest relative that has so far infected the human population. But unlike the others, this one spreads readily from person to person, much like the flu. And that perhaps was what made it so difficult to contain and why many of us are still, not able to get out onto the streets, and those who are working are now obviously recognized essential personnel. And I thank you for your service. But the bottom line is a lot of this could have been prevented. We thought about ways to prevent this and how it might be preventable, but you have to catch it early. And I think that it just hasn't ever happened in history that we've caught one of these in time. We hope for better preparation next time, but hopefully we can do better going forward. One of the things some colleagues and myself started back then in the early 1990s, actually 1993, was something called ProMed, and I'll end on that, the Program for Monitoring Emerging Diseases. The idea was really to have a network worldwide of about 60 different places, like this one, or like the CDC, or some other laboratories and clinical facilities around the world, all over the world, Africa, Asia, even the former Soviet Union, to try to be on the lookout for new and emerging infections that were not yet known, but obviously might be on their way to becoming the next pandemic, something that's still very hard to predict until we see it spreading in the human population. And we developed a system essentially to get everyone on, in those days, email, now on the internet, to discuss and give early warning, essentially, sound the call early if they saw something unusual. And it turns out that one of the first indications we had of SARS in 2003 was a report on ProMed Mail, as we now call that piece of it. Globally, there are subscribers in over 169 countries, and you too can join if you want to read what some people have called the most terrifying news source known to man. I think there are more terrifying things now, but the first mention of SARS actually came to the rest of the world through a notice in ProMed that essentially said, what's going on there in South China? And then China admitted, just about the time of the Hong Kong SARS outbreak, which of course propelled it to world prominence and to many other countries in the world, noticed that China then admitted they had 305 cases going on since November of 2002. In this last outbreak, the WHO found out about this one also from a posting in ProMed Mail. So we do have a number of ways to improve our public health capabilities, our early warning. The next thing is really to be able to respond appropriately and contain these infections early on. And so research continues in understanding, because there may be many infections out there, but many of them luckily stay in their own lane and don't become, like this one, a human pandemic. Thank you for your time, and I'm happy to join in taking questions.
Great, thank you very much. So we'll restart the question and answer period. We have a number of other questions. Here's one I'll throw out to the group. Is there any information on the infection rate among the city's homeless population? Somebody could answer that one or knows information?
We don't have a lot of really good data on this, but we know that the homeless are at very high risk of infection. Recent studies have shown that New York City in general, based on a study done by the New York State Health Department, seems, looking at antibodies in the blood, what we call a serosurvey, to have a prevalence, that is frequency, of about 23% in the people they tested on the street in New York City, which is quite high, but not high enough. It's arguably particularly concentrated in the homeless population, which is very vulnerable because of their living conditions, and of course also in the nursing homes and similar types of assisted living facilities where you have a lot of people close together. So I think anywhere you have people close together and obviously unable to prevent themselves from getting infected and infecting others, you have a dangerous situation. So it's probably high, but we really haven't tested it. And there are studies right now looking at that in the homeless population.
Thank you. Maybe the next question for Dr. Castor. This is about if rioters not practicing social distancing can lead to a spike of COVID cases, and specifically about if racism plays a role there in communities of color.
Sure, thank you for the question. And I'll just add to what Dr. Morse mentioned on the homeless before I answer that, is I think the earliest data we've seen have come out of Boston, where they tested the homeless shelter there, and the reported symptoms of COVID was about 88%. It was quite high in a congested population. I'll try to verify what the actual serologic results were for that, but they were bordering on half, which is quite striking, and I think a very meaningful thing for us to consider as we move into this phase where economic instability will, of course, enhance and perpetuate housing stability and homelessness. So with the question around the risk of increased transmission as a consequence of protests that are happening now, I think the last slide I showed came from a report. I will say that it still needs to be fully vetted and verified, where the estimates were that over the course of this last week with the expansion of protests, there's an estimate of about 21,000 infections attributed to those congestions. And I think as we struggle with all of us individually and collectively with what is an effective action plan that is reasonable both for the biological pandemic and the social one. It's just it's a mind-blowing interaction of how this can really change the curve that we see in terms of trying to really flatten the curve. So I think it's meaningful. Certainly, many of us who are here and think about infections all the time are counting the number of masks that are on faces. And counting how the masks are worn. So not just that it's there, but when it's sort of under the chin or below the nose. And again, as we started off talking about how this is transmitted successfully and the importance, as many of the speakers discussed, the importance of distancing and how long virus can be around. So I think it is a mind-twirling storm, how each wave of this epidemic presents new problems. That is just the intersection of both the biology and the social state that we're in. We are observing, we are participating, we are not just observing as scientists, but also as members of society and participating in how we can try to mitigate those types of risks of transmission.
Thank you for adding that, Dr. Castor. Yeah, I think we'll see a lot of that. I think one of the really not puzzling, but one of the really difficult things in dealing with this is that many people don't show clear symptoms or have mild symptoms, so they don't know they're infected, or we aren't able to detect them. And so they're very likely to pass it on to others without being aware of it, which is why we're recommending many of these precautions. But also for public health people, one of our classic measures is what is called contact tracing. So you try to identify sick individuals or infected individuals. Usually it does start with someone who has some obvious illness, which we call COVID. And then you obviously isolate them so they can't infect others and try to trace, just like in the movies. Some of you may have seen some bad or sometimes good movies showing this process. You try to trace back the other people they have come in contact with and find out by interviewing them or by testing them, whether they themselves might have become infected. And if they are positive on a test or seem likely to have become infected, even if they don't have symptoms, you want to put them into quarantine if if they are negative on a test and not obviously symptomatic, so that they won't be able to come in contact with and possibly infect others. You also find others who may be positive on a test or may have symptoms now, and those obviously would also be kept separate, isolated from other people so they can't pass it down or pass it on to others. And that's our plan really for trying to do this on a large scale now to contain this infection, but it's a massive undertaking. So you've all heard about contact tracing, case identification, contact tracing, and so on. And that's a very effective measure, but extremely resource intensive. And we'll need armies of people to do that. And already there's been a call out for people who are interested in doing that. But it will help to contain the infection. And had it been done early, it would have been a much easier job. It was done early for a while, but not long enough and not early enough.
There was a comment, maybe I could ask one of you to please comment on this, about coronavirus being spread by bats rather than humans. If someone could comment on that comment.
These coronaviruses, SARS, another one in the Middle East called MERS, which showed up about 10 years later and is still ongoing, have their origin probably in bats. SARS, we know definitely by people going out, people like Simon Anthony and Ian Lipkin's group and others going out and testing bats in China, in places like the live animal markets. There's a little bat called the horseshoe bat that in fact is the natural host. It naturally has the SARS infection or the SARS virus, and you can find a lot of its relatives in other bats. Most of the time we don't become infected simply because we may not have that much contact with bats, or it may not be that easy to get infected, but it happens every so often, as it did with SARS. And this one probably also came from bats, because many coronaviruses can be found in bats, and many of them have their origin there. For the bats, they're just like the human coronaviruses of old. They cause something like a mild infection or a cold, but obviously bad news if we get it. But don't blame the bats. It's really our meddling with them and getting into their environments or selling them in markets that has caused this to spread.
Dr. Riley, maybe this one I'll pose to you. There's a question about regarding Dr. Ho's team. Is Dr. Ho's team working on antivirals, antibodies, or vaccines? Which one of these three categories will be most effective long-term?
Well, I think I'll engage Magda also on this question, because she's a colleague of Dr. Ho's for sure. But I believe he's working on convalescent plasma, but specifically on identifying the most potent antibodies from convalescent plasma that will be neutralizing antibodies that could be used for therapeutics and for other applications. And indeed, I think he's had some success in identifying the most potent antibodies from thousands of samples so far that seem very promising in that respect. But he works very closely with Magda, and we could hear a little bit more.
Yes. Can you hear me? Sorry, I had to move a little bit. So yes, indeed, David Ho has sort of been working on identifying kind of those most potent antibodies that human host cell and then causing infection. And that has to do by identifying those patients who've from and systematic review of the antibodies that are produced in those individuals as a result of infection. And then the other efforts that are taking place in his laboratory.
Dr. Sobieschek, maybe we'll come back. I think the internet connection is a little.
Targeting the different parts of the virus replication system.
Yeah, I could probably add a tiny bit to that because Magda's breaking up a little bit. That certainly identifying the most potent antibodies, and in the lab identifying how to target proteins on the virus for therapeutic strategies as well. In terms of vaccinations, I again, not my particular area of expertise. Magda can comment more, but these will be tested. They're already in phase 2b and phase 3 trials, and we're hopeful that these will be coming to some clinical efficacy and use later this year. But of course, we don't know that yet. And it is possible that the vaccines will not be as effective as we hope, or that the virus may change. So it's very important for us to be working on antiviral therapies, antibodies, and additional strategies. I will note that the NIH has taken the challenge of understanding what's happening in diverse and underrepresented populations very seriously, and is just launching a program for several $100 million to study the specifics of diagnostic testing and antibody types within minority populations, underrepresented populations, particularly in socially economic challenged areas. So we hope that this is something that Columbia will be very engaged with these NIH funding strategies, because understanding those differences will help us to understand the best therapeutic strategies as well as the efficacy of vaccines across the population.
Okay, I think we have time for one more question. Maybe Dr. Faroux, I'll give this one to you. Could you talk a little bit about the criteria for admission to the hospital?
Okay, so in the past few months when our hospitals were super crowded, patients that have, so anybody that's severely ill in general would get admitted, which means blood pressure, very low blood pressure, and lab abnormalities that are very dangerous will admit them to the hospital. During the peak of the COVID pandemic, what we've done is some people would have low oxygen level, which is low 90s, but not lower than that. We found, like what Dr. Marie had explained earlier, changing how we operationalize the admissions for sending patients out with oxygen concentrator and the pulse oximeter. And we have a data that's about to be published and making sure that there's also a follow-up for that. But now that our numbers have decreased and the hospitals is not as crowded as during the peak time, now we're admitting any hypoxic patient. And most of the time, these patients have actually turned around. And I would say my last shift about a few days ago, I did not have a single COVID patient on my list, which was a change. And also, but during the peak of COVID, most of things we kind of had to push our limiting our admission criteria. But now anybody that's severely ill, and mostly as the elderly patient with a lot of the comorbidities, and also that have severe lab abnormalities will be admitted. But the message out there for everybody should be what we've said. If you're concerned about having COVID and not feeling so well, our emergency departments are ready to serve you. We have actually, our census have people are still in the community scared of coming to the hospital. If you have any symptom that's life-threatening, and I know most of us in the community do not have a primary care doctor, I would say have a low threshold to come to the emergency department to get checked out. So it depends on all different criteria. I don't want to go into all the lab abnormalities that would necessitate, but a lot of the elderly patients with comorbidities, meaning high blood pressure, diabetes, and asthma or COPD or emphysema, we end up having to admit them to the hospital.
Thank you. I think we've come to our last few moments here. Maybe I'll just ask if any of the panelists would like to make any final comments.
I'll just add about the question of the protests and what's been going on with the racial injustice. I think I can relate to what's going on, at least at the protest level, me being an immigrant doctor, a Black doctor. And in the past few days, I've had the opportunity to go outside. And of course, the bit of the conflict and what Dr. Castor explained earlier, the peak during this time. And scientifically, I've been asked to on different media outlets how I feel about it on both occasions. And I think I feel like, there is an epidemic that, as Dr. Morse explained earlier, It's been racial injustice, a public health issue, it's a public health emergency that we've had to fight for years. And I didn't get the chance to talk about it, but also in our emergency department, we're looking at the outcome of patients based on their race and ethnicity. And some of the preliminary data, we know this from what has been out from the New York Department of Health, but looking at our patient population and see what their outcome was. Did they need to be admitted? Did they die in our emergency departments? Did they die in the hospital? So we're looking at this. So we know that most of us a racism issue. It's not really only about access, and this is something that's been affecting the country and actually I would say most of the world. And it's a big issue, and it's something that we have to advocate for and fight for. And it's an epidemic. We're fighting an epidemic during a pandemic. Of course, there are some public health measures that you would have to do. Maybe if you are protesting and want to protest, wearing your masks and also staying in small groups. And then I'm by no means, encouraging people to go out protest if that's not what you intend to do. But there's a conflict, and I feel like we do have to fight the epidemic and also the pandemic. And by any way, because it's something that you believe for and stand for and you're feeling conflicted about it, I think all of us are on the same page. But what I would say is, as a person of color and also as a doctor, I think it's important that we voice our concerns. And this is me also advocating not only for myself, but also for my patient population who on our emergency department that we see are people of color and different races. So this is really part of the advocacy. And having trained in New York City, working Columbia University, working at a city hospital where I trained in Bellevue, I've had to witness all the structural racism for years. And this is something that I do feel very strongly about. So I just wanted to kind of have that public health message to everyone. Thank you.
This is a very nice way to end the discussion. I mean, what we agree, we have two pandemias. One is infected, the other one is gas season. And we here at Columbia, without doubt, we do promote, physical distance, but social distance among race and ethnicity. And this is at our DOMA here. You have done a great job in the emergency department and in the hospital. It's our motto to put people first. And this is what has been done really, to put the well-being of the people first. Dealing, how you have been dealing, we have been dealing with a very difficult situation at not only low socioeconomic group, but a lot of Latinos, again, at a lot of social determinants of health. I want to thank all the participants on behalf of the GCA department, on behalf of Columbia University. This is an evolving disease. We're going to continue this education. Just a reminder that on Friday at 6 o'clock, we're going to have the same type of presentation, this time in Spanish. That later your family members know, your friends know that the second presentation is going to be to the Spanish language community. But we will continue with these presentations to our community to keep them informed and to keep them educated. It's the mission of the institution, New York Presbyterian Hospital and Columbia University, to really maintain you educated. And this is the first of several webinars that we're going to be doing to our community. Good night.
Rafi, Dr. Lantigua, thank you very much. And I will close by a couple of things. Thanking, of course, all our panelists, Dr. Mills, Dr. Riley, Dr. Lantigua, Dr. Castor, Dr. Sovietchik, Dr. Romney, Dr. Farouk, Dr. Morse. I think I got everybody. I really think you all added a tremendous amount to this discussion. I hope the folks watching on YouTube found the discussion interesting and informative. For those of you who we did not get to your questions, I apologize. We hope to do additional forums in the future. We will keep you informed. Please do feel free to send follow-up questions to cumcgca@columbia.edu, and we will forward them to the appropriate panelists and try to follow up with an answer. As always, I would be remiss if I did not thank again the staff of the Office of Government and Community Affairs, especially Janelle Edwards, and who's been working so hard on this for the last couple of weeks. Also, a special thank you to Bashar Mackay, who I feel sometimes has been on loan to us, if you will, from our colleagues down at the Morningside campus. And with that, I will just wish you a good evening. Stay safe, maintain social distancing, wear the masks, do all the things that our experts have instructed you or advised you to do tonight. And with that, thank you very much and have a good night.
Thank you.